2024 interim meeting of the Commission on Race and Access to Opportunity to order. Lead staff is Brandon White, and the committee assistant is Logan Schaff. Mr. Schaff, would you please call the roll?
Senator Berg. Present. Senator Neal.
Present.
Senator Westerfield. Representative Brown.
Here.
Representative Heverin. Representative Kulkarni. Ms. Baird. Mr. Coleman. Mr. Davis. Mr. Pryor. Ms. Smith-Willis. Co-Chair Bledsoe. Co-Chair Timoney.
Here. Thank you for that. We do not have a quorum to approve the minutes, so we'll bypass that. Do we have any members that have any comments or recognitions at this time? I would like to point out to, for those of you who remember our education session that we had, William Wells Brown, their test scores were phenomenal. Again, and probably to this committee, no surprise. They had the largest growth scores of any school in Fayette County, which is outstanding. So that's definitely a school to watch for sure. So we need to make sure that we give all the accolades to Dr. Hutchinson and her staff. They did an outstanding job, and they keep showing up.
Mr. Chair,
Yes, sir.
if I may, they invited us to come for their opening day, and I went over and spent time with them. And then I've been dropping off goodie bags with materials and books for the school. I think they're headed in the right direction. A lot of good things are happening over there at William Wells Brown.
Yes, sir. I saw you on that first day, and that energy, it's undeniable. I mean, it's the first day of school, and you already saw staff members connecting with students and their families, even the new families that had never been to William Wells Brown. So definitely have a recipe for success over there. I do want to remind everyone the purpose of this commission shall be to conduct studies and research on issues where disparities may exist across the sectors of educational equity, child welfare, health, economic opportunity, juvenile justice, criminal justice, and any other sectors that are deemed relevant in an effort to identify areas of improvement in providing services and opportunities for minority communities. I know I'm really excited about our agenda for today. We have Dr. Edward Miller. Sir, I was looking at your resume. It seems like you're a coast hopper. You started on the East Coast and went out west and then came back. So I'm glad you came back. We are one of the reasons why I'm excited about this one is one of the issues that we as a country face as a nation, as one of the leading industrialized nations in the world, is that we have a very poor maternal mortality rate, particularly in the African American community, and it's something that we have to keep asking questions about, keep studying, keep learning, and keep making suggestions on improvement. And so I'm really excited about hearing your presentation today. So turn it over to you, sir.
Thank you so much for having me. It's good to be with everyone again. My name's Edward Miller. I've been in Louisville for 5 years. I moved here after fellowship from California, coast hopping. I currently serve as the Division Director of Maternal Fetal Medicine and High-Risk Obstetrics, and in that capacity, also chair our Diversity, Equity, and Inclusion Council for U of L Health. I'm here today to speak with you again briefly about the overall state of maternal health in the Commonwealth of Kentucky. And my goal is to really start the conversation and the consensus that there's no longer a choice to act, or if we don't, we need to start somewhere. Fortunately, since I have coast hopped, I've been to a lot of different places, and I would love to have really robust discussion about real policies and initiatives that other states are doing, other hospital systems here in Kentucky are doing to make some long-lasting change. I have no disclosures. So again, I briefly went over the objectives at the beginning. We're going to do a review of maternal health in Kentucky and the development. And as we talk about the maternal health status of Kentucky, I want everyone to frame it in the mind of, when does a healthy mom, care for a healthy mom start? At what point? Is it when the pregnancy test turns positive? Is it when their child's born? Or is it much, much earlier? We have to frame that in all of the conversations and policies, because as we talk about social determinants in health and other things, we'll find that every policy that we make, whether it be housing, economic stability, is really policy regarding maternal health, and it really does make huge impacts. We will briefly review the Maternal Mortality Review Committee data, and finally, and I hope the bulk of our conversation today is a discussion of policy that some of which we've already enacted in Kentucky, some of which is adopted from other states that can really improve maternal health in the Commonwealth. So before we get there, we have to go over a couple of key definitions and what is health equity. Health equity, quite simply, is the goal of everything we do in healthcare. It's everything that we do as public servants. Health equity is the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health regardless of their race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, or other factors that have affect access to care and health outcomes. The Kentuckiana Healthcare Collaborative further defines health equity attainment and states that health equity is achieved when everyone can reach their full health potential. That is such a simple statement, but it is so profound. When everyone can achieve their full health potential, and no one is disadvantaged from this potential due to socially determined circumstances, constructs, or position. And I know that in today's current climate, we talk about social determinants of health so frequently and so often. But it's so important that we frame all of our conversations about policy regarding and in the context of social determinants of health. These, especially as the Commonwealth becomes more diverse, these social determinants of health drive and really are the basis behind so many of the disparities that we see in our work and practice today. For those that are unaware, the CDC states that social determinants of health are the environments where people are born, live, work, play, basically everything we do and interact with on a daily basis that affect a wide range of health, functioning, and quality of life outcomes and risks and metrics. Social determinants of health can be exacerbated by racial prejudice, discrimination, social injustice, and can disproportionately impact our marginalized communities. So when we look at the Commonwealth, what are the 6 largest drivers of social determinants of health that lead to healthcare disparities that we see? In no particular order, they are economic instability, neighborhood and physical environment that our Kentuckians are living in, education, food, community safety in a social context, and the healthcare system and health literacy. 80% of a person's health outcomes are influenced by those factors rather than the medical care that they receive, which is significant. Before a patient even sees their doctor, 80% of their outcomes are determined by the life that they've lived before they get to their doctor's office. Which takes us to this key point before we dive into it. Health outcomes are multifactorial. We have not gotten to this place because of simply racism alone. We have not gotten into this place because of simply lack of access to care. There's multiple reasons for why we're in this place today, and there's multiple ways that we are going to have to dig out of it. So when we look at prioritizing social determinants of health, how does this look? Well, we have great examples locally of local organizations that have utilized identifying social determinants of health to make a huge impact. So we all remember in July of 2022, the devastating floods that hit Breathitt County. And Juniper Health, which is a healthcare provider in that area, recognized that there was a considerable strain on their available resources. The floods destroyed food pantries, they destroyed several churches that provided additional resources to the community. And in response, Juniper Health initiated something that the first policy I would like us to think about is how are we monitoring social determinants of health as a state? Juniper Health initiated a program called the Protocol for Responding and Assessing Patients' Assets, Risk, and Experience. They call it the PREPARE social determinants of health metric. It is a national standardized patient risk assessment tool designed to engage patients in addressing and assessing social drivers of health. It's evidence-based, and most importantly, it's also associated with toolkits that you can use to then implement action after you have identified social determinants of health or problems. As a result of their implementation, Juniper Health facilities were able to successfully identify both immediate and long-term community needs far above that of their peers. Now, why is this important, and why is this something that we can implement immediately? Social determinants of health are collected by every healthcare organization. Every healthcare organization on their intake forms asks the same questions. However, it's a matter of what do we do with that information? We have valuable information in our patient records that we are not currently utilizing to optimize and to maximize patient care. Validated measures like the Prepare metric offer the states like Kentucky an opportunity to make data collection uniform, and more importantly, it offers us to use near zip code level precision to identify differences in social determinants of health by zip code, which is really, as we get to it, what we're going to have to do as a Commonwealth. As we all know, this is a very unique state, from urban centers to largely rural centers as well. A one-size-fits approach is not going to fit, and measures like this allow us to really use what is going to be precision medicine to really pinpoint exactly what interventions need to be made by each individual zip code, which will greatly impact overall patient care. So we'll go a little bit fast through this because I know that we talk a lot about these things, but the goal of this initial part is that every part of a person's life impacts maternal health. Poverty, which is something that disproportionately impacts women of the Commonwealth. There are significant disparities in poverty rates. You're going to see a lot of maps that look similar to this. And what I want you to take away is, with almost all of these maps, when we look at which groups are most impacted, you could almost overlay every map on top of each other, whether we're talking about poverty rates, maternal mortality, hypertension rates, diabetes rates. They look almost exactly the same. Certain regions are impacted more than others, and then they all kind of lead to the same result. Poverty represents a particular crisis, not just in Kentucky, but disproportionately impacts communities in Appalachia. The median household income in Appalachian Kentucky is 31% lower than the rest of the state, and the household poverty rate is 26.7 compared to 16% in non-Appalachian regions. When we talk about the impact of poverty on maternal health, it is immense. Poverty affects all-cause maternal mortality. If you are a woman in Appalachia and you are in middle or high poverty areas, you are 60 to 100% more likely to suffer from maternal mortality or die compared to women that were born in low poverty areas. That risk is increased if you are a minority as well. There's an increased risk of a variety of pregnancy complications. We're talking preeclampsia, preterm birth, low birth weight. But along with all those pregnancy risks, there's all the other things: malnutrition, maternal mental health, which we'll touch largely on, healthcare access. As we talk about expanding services and legislation and things like doula services, which we'll talk soon about, the access part is one of the key drivers we have to look for in Kentucky when we're looking at our current physician workforce. We have to expand our workforce, but we also have to diversify the workforce because we are in a primary care physician huge hole in the state of Kentucky. So when we look at particular metrics in conditions for which Kentucky has scores lower than the rest of the country, cancer is a great place to start. Cancer affects families, cancer affects maternal health, cancer affects generations. Kentucky is first in the nation in cancer-related deaths with a rate of approximately 185 per 100,000 people. We rank first in the country in average number of new cancer cases. This is we have 503 per 100,000 per the national average of 436. And when we look at types of cancers, we have the highest rate of new colon cancer cases, the highest rate of new lung cancer cases, the second highest colon cancer detection rate, the second highest pancreatic cancer rate, and the third highest laryngeal cancer rate. Now, if you look at all those cancers, all of those cancers are highly associated with obesity and smoking. Okay, so there's reasons why. When we look at cancers like that affect women, when we look at ovarian cancer, we actually have one of the lowest in the country in ovarian cancer rates. But the two important cancers that I want to identify are cervical cancer and breast cancer. Cancers that have the opportunity with preventative screenings to be detected early and be considered treatable. Kentucky has one of the highest new incidences of both cervical cancer rates and breast cancer rates. And why is this? Well, number one is access to resources. As we talked about the impact of poverty, poverty can impact a person's ability to access medical care directly or indirectly. There's also, with poverty, there's less resources given to the importance of screenings and preventative screenings. A study recently shown that if you have a positive pap smear or mammogram, you need 3 to 4 more visits to get a confirmatory diagnosis. So if you have limited access to care, if it takes you an hour to get to the doctor's office, that's 4 trips, each an hour apart, that you need to get a confirmatory diagnosis. And that barrier is in place for many of our women that are the most vulnerable in rural regions and in the lowest socioeconomic regions. As we talked about as well, there's a higher smoking incidence rates with adult smokers in Kentucky, which greatly contributes to the increased cancer rates and then the obesity rates as well. And as I mentioned before, breast and cervical cancer diagnoses are highest in the southern United States, with Kentucky recently being found to have one of the highest rates of both. Researchers from the University of Kentucky in a study in 2022 found that post-COVID, 30% of women were 30% less likely to have pap smear testing post-COVID in 2022 than they were in 2019. That's despite the increased emphasis on public health and on preventative screenings that occurred after the COVID-19 pandemic. And it's particularly concerning, as I mentioned, given that cervical cancer is a preventable condition and a preventable disease. And most recently, a study from the University of Louisville found that only 48.6% of rural women in Appalachia received a pap smear compared to 64% of urban women. Which takes us to preventative care in the women of the Commonwealth. So this is a huge area of emphasis and huge area of opportunities for growth for us as a healthcare system and as a state. There are areas, when we look at our rates of preventative care, there are areas where we are doing better than national average. In 2022, 6% of women in Kentucky of reproductive age reported not having health insurance. That's lower than the 10% national average. Only 12% of Kentucky women of reproductive age said that they needed to see a doctor in the last year but couldn't afford to. That's below the average of 17%. But despite some positives, preventative care is a huge area of opportunity and concern. When we look at just some of these stats, we are 5% less likely to get mammogram screenings. Women in Kentucky are 17% less likely to get their pap smear screenings than women in other states, and those are then key drivers of adverse maternal outcomes and maternal health. So when it comes to obesity in the Commonwealth, this was a really powerful figure. So obesity is a worldwide epidemic, not just something in Kentucky. Obesity affects 1 in every 8 people in the world, 1 in every 3 in the United States, even more than that in Kentucky. But this graph is the key takeaways of people in Kentucky. This graph shows what percent of people think that childhood obesity is a problem by region. And what you see here is Eastern Kentucky, an area that is disproportionately impacted by obesity, doesn't think that childhood obesity is as big of a problem as they do in areas where they have less of an impact. And what it means is that oftentimes these life experiences and these life lessons are internalized, and as a result, it just becomes your day-to-day. You don't see yourself as sick or as different. And as a result, you have the impact of obesity on the Commonwealth. In 2024, the overall obesity rate in Kentucky was 41% compared to 34%. Women aged 45 to 64 was the age group most likely to be impacted by obesity, and there are significant disparities in obesity by race. 72.7% of Black adults are overweight or obese compared to 60% of white adults. And as we've mentioned before, obesity rates vary largely by county, ranging from 31% to 47%, with the highest rates being seen in Appalachia. And this graph really nicely shows the cost of obesity both nationally and in the Commonwealth. It's one of the largest drivers of excess healthcare costs. And the impacts, similar to poverty, are immense pregnancy complications, including hypertension, diabetes, preeclampsia, and noting that those complications don't just affect pregnancy, they affect subsequent pregnancies, they affect future health as well. The metabolic changes that occur, heart dysfunction, childhood health. One study that just recently came out in JAMA showed disparities in obese patients from rural areas being offered things like Ozempic or GLP inhibitors in an effort to decrease the risk of type 2 diabetes and those things. If we look at disparities, it goes beyond new medications like Ozempic. Look at disparities in diabetic children from West Louisville or from Appalachia that have ever had an insulin pump. They're type 1 diabetics. Standard of care is an insulin pump. They should have known about insulin pumps their entire lives, but they're not offered it. They don't even know about it, or if they're offered it, they don't know how to use it. Versus affluent areas, pumps become the standard of care. What is important about that? Not only do children with insulin pumps have better control of their diabetes, they have more autonomy over their lives. They're not having to stick their sugars as much. It's not as much of a social problem, and as a result, they're able to do long-term well care better than children from lower socioeconomic status. And those are the kind of things where not teaching at that early age leads to the long-term outcomes of type 2 diabetes, which we'll talk briefly about. Obviously, we all know the impact of substance use in the Commonwealth. And as we'll see when we review our maternal morbidity and mortality data, 58% of all maternal deaths had substance use as a contributing factor. That's actually probably underreported from the data. Kentucky has been disproportionately impacted by the opioid and substance use epidemic, with substance use-related deaths near the tops annually. And as a result of these statistics, addiction remains one of the most critical public health and safety issues facing women in the Commonwealth. Addiction rates remain highest in women of reproductive age. When we look at substances, we're talking fentanyl and methamphetamines as the major drivers. Methamphetamines is one, especially locally in Louisville, that is becoming more prominent, and the long-term impacts, particularly regarding heart disease and cardiovascular remodeling with methamphetamines, are really pronounced, and we're only going to start seeing them more as we start seeing it more frequently. As we see from the graph on the left, in 2020, near the COVID pandemic, in 2021, we reached a high of 2,257 overdose deaths, and then those numbers fell. In 2023, they fell below 2,000, and those decreases were due to a myriad of initiatives, such as the availability of Narcan at widely, and the increase of visibility of medications like Subutex and Suboxone. And this kind of goes back to the importance of utilizing social determinants of health when we make these implementations and these changes. Despite making significant changes and decreasing the amount of overall overdose deaths, there were still disparities within the overdose deaths that we saw. And we saw that Black women, while their overdose deaths decreased, they decreased by only 5% compared to the 23% in other groups. So as we make these policies and changes, the question is, well, where are we advertising the role of Narcan? Are we going into all schools? How are we making it clear that this medicine is safe and available? How are we doing that? And all of our social policies and all of our health policies have to have that in mind, which is the importance, again, of studying the social determinants of health and making sure that our community partners are a part of our engagement and strategies. This is an area where I actually think Kentucky's doing a whole lot in the realm of mental health with policy and initiative. So according to America's Health Ranking, 26% of women aged 18 to 44 who live in Kentucky reported that their mental health was not good 14 or more days in the past 30 days. That 14 days is important because that 14-day mark puts you at significantly increased risk for depression and associated mental health disorders. This leaves Kentucky ranking 48th in the country in terms of mental health distress. And obviously, with mental health comes a significant risk of smoking, alcohol use, substance use, and all the other potential adverse outcomes that can come from that. So we talked about the role of obesity. We're going to kind of go really quickly through the final three conditions that really disproportionately impact individuals in Kentucky with diabetes, hypertension, and cardiovascular disease. Women in the Commonwealth are disproportionately impacted by diabetes and heart disease. Kentucky ranks 39th in the nation when it comes to the overall diabetes control, and an African American in Kentucky is 2 times more likely to die of the impacts of diabetes than their white counterpart. This graph is pretty striking. This looks at diabetes in women aged 35 to 44, and they found that 40% of Kentucky women aged 40 to 74 have prediabetes, and they don't know it. And that probably is actually underdiagnosed or less. But you compare that to 5.6% of Kentucky women have gestational diabetes, which means that from the time that they have their baby to the time that they get diagnosed with prediabetes, there was so much time and opportunity for intervention and identification. But if those patients don't go back to their doctor, if they don't have a primary care provider, they're not getting the help or the services that they need, and they're getting diagnosed at a later stage. And similar to other conditions, diabetes is manageable and it can be preventable. You can prevent all the long-term sequelae of pregnancy complications, blindness, heart disease, kidney failure with simple medication and patient and access to care. Similar to the other graphs, hypertension is an epidemic in Kentucky. We'll kind of go through these, as well as cardiovascular disease. So they all kind of take us here. So the impact of high blood pressure, diabetes, kidney disease, all these things on birth and on preterm birth, on the start that kids get. So the preterm birth rate in Kentucky is 11.7%. It actually went down, but it's from 12% in 2022. But when we look at the stats on preterm birth, we can kind of break it down. Preterm birth, by definition, is birth before 37 weeks. That 37-week mark is a really, really important stratifier. It's further classified into late preterm birth, which is 34 to 37 weeks, moderately preterm birth, which is 32 to 37 weeks, and very preterm birth before 32 weeks. That very preterm birth mark is a really, really important marker. It's in those very preterm birth that those babies are having the months-long NICU stays, the $100,000 hospital bills, and more importantly, are at a very increased risk for long-term sequela, whether it be neurologic problems like cerebral palsy, long-term cardiovascular problems, or pulmonary problems. And it's in those children that they put a substantially increased price on not only the healthcare system, but the price of prematurity on the family as well. A 32-week baby for a woman in Appalachia will cost about $58,000 in family wages, even when their median salary is below that $58,000. So a preterm birth literally economically will ravage a family for the long term. And when we look at state summaries in Kentucky, there's lots of stats here from the March of Dimes. 1 in 11 babies were born low birth weight. 21% of infants born in Kentucky did not receive adequate prenatal care, and 1 in 9 babies born in Kentucky were born preterm. And this makes sense. Why are babies born preterm? Why are we getting a grade of an F from the March of Dimes? Well, these are all your risk factors for preterm birth: hypertension, diabetes, unhealthy weight, previous preterm delivery, carrying multiples. All of these conditions were disproportionately impacted by in Kentucky. So all of this kind of goes back to the start that we get and the start that our kids get off to. And this graph is really the take home of the next phase of the conversation of when we talk about things that we can do and policies that we can put into place and things that other states are doing to impact maternal health. We have on the left the pregnant mom, the premature birth, and then the future child and the health outcomes. The impact of prematurity, we talked about social determinants of health. We know the impact that they play. Just the very impact of prematurity puts a child at a greater risk of so many adverse health outcomes, from cardiovascular disease to pulmonary disease to being, if you're born preterm and can't be breastfed right away and can't have human milk, you have less gut health. You're more likely to have infections at an early age. You're more likely to have asthma. Literally, preterm birth sets you up for a wide range of long-term health problems. So when we talk about where to start, there's so many places, but each of these has their own different starting point where we really need to focus on. For sake of time, we'll kind of go through this Maternal Mortality Review Committee data. So the Kentucky's maternal health and well-being has a significant impact on the overall health of the state. This is our MMRC data. We found that the vast majority, the most significant cause of maternal death was from natural causes. Accidents were second. Homicide and suicide, those are actually sometimes hard to flush out separately. But what we know is that there are disparities in the rates of maternal death between Black moms and white moms, consistent with other states around the country. This is a really important graph that we'll focus on that came from the MMRC data. So this looks at the timing of deaths. For years, maternal review committees looked at death and they stopped at 42 days after the pregnancy was delivered. We've just started recently going beyond that, going from 43 days to a year, and it's so important, and this graph shows why. Had we not gone beyond that 43 days, we would have missed all of these, the majority of deaths that occur. And this is the period of time that is most critical, from the postpartum period to the getting patients in and integrated into the healthcare system. So think about it. You are a pregnant mom, you had a very difficult delivery, you had type 2 diabetes, you had severe preeclampsia, you had a C-section emergently. You're 6 weeks out, and then normally we would have stopped looking at your outcomes at 6 weeks. Your battle's just started at that point. You are literally still recovering. Your body's getting back to you. The impact on your heart, on your kidneys, on your organs are still being impacted. We're now just starting to look at what's happening to these women. Furthermore, these women, especially with limited resources, now have to find the care that they need to get in with their cardiologist, their endocrinologist. They may have to navigate a healthcare system for the first time at the most critical time in their life with the least amount of resources that they've ever had. So this graph is really a big impetus for the establishment and the expansion of doula services, which I think is a great conversation that we can have today. And finally, this graph from the MMRC looks at where these maternal deaths are occurring. And as you see, there are some significant disparities here. We see a consistent number in the Appalachian regions, and then concentrated areas of maternal deaths in areas where we have a lot of our tertiary care centers as well. So the takeaways from the 2023 Maternal Mortality Review Committee report: 88% of maternal mortality deaths were deemed to be preventable. That is the takeaway. I mean, that number is striking, and I actually think that it's underrepresented. If you think about social determinants of health, if you actually take it back to improving a child's life when they're growing up, I actually think it's greater than 88%. 28% of maternal deaths were pregnancy-related deaths. Over 50% of maternal deaths occur within 43 days to a year of the end of the pregnancy. 60% of mothers without documented prenatal care had Medicaid-funded health care, and 58% of all deaths had substance use as a contributing factor. So the most important part about the Maternal Mortality Review Committee report is not just their takeaways, but their recommendations. The recommendations from the 2023 report was that clinicians and facilities should establish guidelines for mothers with or without prenatal care, with coordinated referral among primary physicians, obstetric providers, substance use disorder specialists, and infant providers. In essence, the committee found and recommended that we needed to coordinate care for our most vulnerable women with more resources and more community involvement. So we've got work to do, and we have a couple of good starting points. So a place that I thought we could start is something that passed through Kentucky legislation. So Senate Bill 74, which aims to support maternal and infant health, reduce the high mortality rate for mothers, established a state maternal fatality review team, and required state Medicaid services to cover lactation, consulting, breastfeeding equipment, and in-home and telehealth services. A huge start, a huge push towards increasing access to care. But when we look at it in the day-to-day, when we look at actually what increased access to care looks like in the current healthcare system of Kentucky, what does this mean? So this is a graph that looks at the amount of OBGYN providers by county in the Commonwealth. Kentucky currently ranks 40th among the states in primary care physicians per 100,000 people. If we look at this map, all the counties in white have zero access to an OBGYN to them. Counties in the darkest blue have 12 access to 12 to 25. So those are the most concentrated areas. When we look at the shortage of obstetric services and pregnancy-related services, nationwide, there's going to be around a 90% shortage of supply of OBGYNs by the year 2030. So, by the year 2050. So the question is what do we do about that? How do we expand care services when we're not getting physicians and healthcare providers to these communities here? Well, there are a couple of great examples that we can look at in ways that other states have done it. So the Primary Care Development Corporation, or the PCDC, released a 2022 state trends report, and their goal and what they were looking at was how do we increase investment in primary care and improve primary care outcomes regardless of what state you reside in around the country. And they set 4 key areas for development. Number 1 was improving the way we pay for care so that providers are paid for delivering the right care to the right patient at the right time. Increasing reimbursement for primary care, investing in primary care infrastructures, and investing in both the existing primary care workforce and the pipeline, which means so many things. I mean, those 4 recommendations are so broad. From the pipeline, that is investing in schools. That is investing in homegrown talent that is going to stay here. We have a couple of great examples of those things working. So the University of Louisville recently received a $16 million HRSA grant to train medical students to train locally in primary care and to stay in Louisville. And that's important for a couple of different reasons. We know that if we get kids from the Appalachian region and they stay here for school and we make this attractive for school. Not only are they more likely to work in Appalachian regions, not only are they likely to take care of people that look like them, like we know from when you recruit minority physicians, they're also more likely to accept Medicaid patients and patients that have insurance that is not privately funded. So there's so many benefits of putting time, financial resources, and effort into recruiting your own to serve their community in the end. When we look at what other states have done, in 2023, at least 3 states increased Medicaid reimbursement rates for primary care, moving closer to Medicare parity. If we look at Kentucky's is one of those on those lists. In the supplemental files that I'll send, there's a fantastic link to how each individual state approached each of those 4 different parameters in an attempt to improve their primary care workforce. What they found is that the critical next steps in stabilizing and recruiting and diversifying the physician workforce is recruitment of medical students into primary care. This is a big area. This is difficult. The cost of medical education is immense for many students. And as a result, when they're forced to make that decision of what specialty to enter, primary care specialties do not make as much money as other specialties, and that is a driver for a lot of students. There's been many different techniques used by states. Some have done student loan repayment. Some have offered fee for service. So for every year that you work and give back to Kentucky, they pay off a year of your school. There's many different things that have been looked at that have worked. Retention of current primary care providers, expanding access to care through telehealth. We've learned through COVID that telehealth works, and that expanding access to care through telehealth can provide life-saving services. Creating comprehensive primary care through integration. This is an exciting area where I think we're going to have to recognize the future is. When we recognize how we're going to expand care and services to areas of Appalachia, how we're going to expand tertiary care services to areas of Appalachia. It's not going to necessarily be to build a hospital there. It's going to be to bring centers and resources from other areas to there in a financially and fiscally responsible way. And then, as we've done in Kentucky, expanding postpartum benefits and expanding access to postpartum coverage and services. So these are a comprehensive list of states that in 2023 passed maternal mental health legislation. Kentucky's on here a couple of times. But when we look at specific areas like maternal or Black maternal health awareness or provider education, there's definitely areas where we can increase our impact. Which takes us briefly, these slides are a little out of order, which takes us briefly to a conversation that a lot of us have been having about the expansion of doula services as a way to improve maternal health. There are multiple benefits of doula services: fewer cesarean sections, less anxiety and depression, less pain relief, shorter time. Quite simply, doula services save lives. Doula services save lives. And expansion of doula services is not only about the facts on here. Doula services are also more likely to tackle the social determinants of health that play a role in adverse maternal outcomes. There's been multiple studies that have shown that Black women that have doula care have better outcomes. At this point, from studies in California, from studies where they've expanded doula services, it's clear that every pregnant patient, every pregnant person should be offered doula care as a part of their prenatal care. So what is a doula? A doula is a trained professional who provides continuous physical, emotional, and informational support to their client before, during, and shortly after birth to help them achieve the healthiest, most satisfying experience possible. Doulas do a wide variety of things. Doulas can reduce the impacts of racism and racial bias in healthcare. Doulas can be an intermediate between the healthcare system and the patient. They do a wide variety and offer a wide variety of services. Patients who utilize doula services are 2 times less likely to experience a birth complication. They're 4 times less likely to have a low birth weight baby. They're more likely to breastfeed, and they're more likely to feel happy about the care that they received. And if they feel happy about the care that they received, they are more likely to follow up on postpartum visits and assist and obtain postpartum care and for the management of any chronic conditions that they might have. So if we look at states that have implemented doula services or are in the process of it, we can see that many states are at least in some process or in some way examining or looking at the impact of increasing or expanding doula services to their constituents. In Kentucky, we've had multiple conversations, but we do not have legislature that has actually been passed that is looking at Medicaid paid for doula services. But if we look at examples of states that have done it and have done it successfully, Oregon was the first state that successfully expanded Medicaid access for doula services. There's a couple of key questions that consistently come up when we look at states and their analysis of how they were looking to expand doula services. Number one is what is the training and licensing and requirements required for the doula? Doulas have a wide variety of backgrounds. You will have some doulas who are unlicensed that have been doing it for 20 years, who have delivered hundreds of babies. Other doulas who have been doing it for much shorter amount of time that have a license. So what is the licensing requirements for the state is one big question that they have. What is the reimbursement structure? There's a wide variety of reimbursement structures that states have adopted to pay for their doulas. Some are a fee for global service. Some are fee for care, for visits. Some pay one rate for labor and delivery for support and then another rate after. And then the billing procedures as well. The doulas have to be registered Medicaid providers. How do the doulas do that? What if the doulas are employed by a hospital system or those kinds of things? So those are unique questions that we would have to ask ourselves as a Commonwealth and adapt it to us. But most importantly, when we look at the rates and the disparities of birthing persons in Kentucky, it's clear that doula access and access to a doula would save lives in the Commonwealth. It's also clear, based upon our demographics, that the initiation of doula pilot programs would be a fantastic first place to start. What works in Appalachia is not going to work in Louisville, it's not going to work in Lexington. There's also very different amounts in the availability of doulas in each of these regions, in these areas. We also have to make sure that, doula care, midwifery care, there's fantastic studies. The next step is questions like birthing centers, which I know has been a question, but making sure that all of those things are equitable as we look at expansion of those services. There's been fantastic talks about the expansion of doula services, but I think that at this point, the data is clear from other states that those expansions, those services are life-saving potentially. So I will end with this final thought that the epidemic of Black women's maternal mortality has been known for more than 10 years. It's now common knowledge, and now this is a fantastic opportunity because the data from here in Kentucky shows that we have to start. We've made fantastic strides with the passage of some bills, but now it's about having conversation, and hopefully a really good conversation today about things and real concrete examples that we can do to expand services to improve maternal health in Kentucky, because we have a long way to go. So I'm happy to take any questions.
Thank you, sir. That was eye-opening.
Depressing.
I wasn't going to say depressing. I was going to try and use a different word. But what's the expression? How do you eat an elephant? One bite at a time. Mm-hmm. So let's start talking about what we're gonna eat first. So, Senator Berg.
Thank you for an exhaustive presentation that honestly I think should be given to Health and Human Services, because we need to hear the same exact data in that committee. But I do have some questions, just specific questions about the doulas. One, does that $1,500 cost get paid back? Is it cost effective? Do you end up saving that money in the long term? Two, our current OBGYNs, are they going to object to the insertion of a whole different person into that healthcare cycle? And or why are they not able to offer these same services to their patients if we know that they significantly impact outcomes?
Absolutely. So from a cost perspective, the cost of a doula, if you prevent a cesarean section, you've paid for the cost of the doula. for that entire pregnancy. And statistically, you are 2 to 3 times less likely to have a C-section if you have a doula. So you've paid for your doula services for that pregnancy, let alone the cost of decreasing prematurity and those kinds of things on the healthcare system. So absolutely, like long-term doula services are cost effective. When it comes into the integration into like the OBGYN team, that is a case-by-case situation, I think. When you look at the benefits, however, that a doula brings, and when you look at the fact that in a perfect world, your provider is somebody that you trust, that you have a good relationship with, but we know that healthcare disparities are also driven by distrust and mistrust of the healthcare system, which may include your OBGYN. So I would argue that even if the OBGYN doesn't value that doula, if the patient does, that supersedes the OBGYN's valuing of the doula. And the OBGYN has to recognize the importance of the doula as a member of the healthcare team. It's just up to the healthcare organization to determine what role that doula will play. I'll use an example. Certain hospital systems like Norton Healthcare actually have employed their own doulas that are employees of Norton Healthcare. So those doulas play a different role than a community doula would, who has no duty to the healthcare organization, and their duty is only to support that pregnant person. So there's multiple different ways and avenues that you could do this and implement doula services.
Mr. Pryor?
Yes. Thank you, Dr. Miller, for the presentation. I wanted to zoom out back to kind of the social determinants piece of this, because I think, a lot of my colleagues on the commission also have roles in other spaces. One of the things you highlighted in terms of kind of top impacts on maternal health was neighborhood and physical environment. I assume, does that include housing? And if so, can you talk a bit about the impact of housing or lack thereof on maternal health?
Absolutely. So it impacts housing. On one of the slides, housing was one of the 6 key drivers of adverse outcomes. And if you hear lack of housing, lack of ability of safe housing, I think you can't separate that from the lack of safety in that emotional context too, which was another social determinant of health that impacts adverse outcomes. What we know from data from lack of housing, poverty, those kinds of things, is that there's an increased level of stress in all mothers that are going through those things. And there's been fantastic data on the linking of stress and weathering. This idea that the chronic stress of poverty, of lack of stability, leads to higher blood pressure, more adverse outcomes, increased risk of preterm birth. And it's actually scientifically studied that those things basically age you faster. They weather you faster because of the chronic stress of life. It's actually, there's really, really fantastic stories about this, but it's the exact same reason why Black girls that grow up, Black girls, regardless of their socioeconomic background, they hit menarche faster because the chronic stress of evolution has made them have to grow up faster. They develop secondary sex characteristics earlier because that is a biological evolutionary reaction to it. And it's the same thing with lack of housing. It may just be more acute. It's just a symptom of social determinants of health and how it impacts pregnancy.
Well, thank you. And then the other is just, can you delve a little bit more into the high rates of suicide? What more do we know about suicide in Kentucky? Perhaps drivers thereof, if we have any sense of that. Can you speak to that?
In a pregnancy context, we know that our suicide rates are largely linked to, especially in the postpartum period, a lack of identification of postpartum depression, signs, symptoms, warning signs, and a lack of resources once we've identified. There's actually been great legislation passed that is attempting to combat that. However, we still come down to the resources that are there. If a woman has I'll give an example. If a woman, if a pregnant patient comes into the hospital, they're postpartum, and they go to the emergency department because they say, I just don't feel safe at home, and they have no suicidal ideation or homicidal ideation, they are sent home with their child, with all of the stressors that they have. They are sent home to then try to make it. So it's the systems that we have in place to support these people through all of these things that are lacking, and that's a big. It's part of it is the ability of the healthcare system to accommodate this extra volume and this extra load, which we're already stretched thin. Obviously, mental health resources. Again, this is an area where doula care is a huge part of decreasing. We know that they decrease postpartum depression rates. We know that they improve maternal mental health. It's another reason, and more importantly, they are an provider extender. Even though they may not be hired by the healthcare system, they're another person that patient can call when they're feeling overwhelmed, when they're feeling stressed, that has a healthcare background, that might be able to make the phone call that could save a life. And then obviously, of course, substance use disorder plays a large role in the high suicide rates as well.
Okay. Thank you.
Senator Berg?
I did have another question, and you brought it to my mind. This Juniper Health, how do you implement something like this? I mean, was this just done within one local health network?
Got it?
So each individual healthcare network, like each of our MCOs, would have to adopt this. And then once you gather the data, what do you do with it?
So once you gather the data, I mean, what you do with it, it depends on your view of healthcare and how you think we should be delivering healthcare. So once you gather this data and you're able to say that these zip codes have the highest rates of suicide and food insecurity, well, then you bring in resources, hopefully from the community or in other places, to combat that. And then you recognize that these zip codes may have higher incidences of lead and those kinds of things, and you make really tailored, targeted decisions based upon those, and you recognize that you start delivering care a little bit differently. You have the same resources, but the allocation of resources are different based upon the stressors that you can determine. Most importantly is all data can be helpful, but we're collecting this data and not doing anything with it. We already have it. So it's almost, when we talk about 88% of deaths were preventable, well, with this data, it might be 92%, 94%. I'll use an example of something that we're doing at the University of Louisville. We are starting a Black women's maternal health clinic, and social determinants of health are the drivers of that clinic. So we have a community advisory board. A patient fills out a survey very similar to that PREPARE survey, where we figure out their social determinants of health, and then we have the community advisory board that gets together. That patient's packet comes up, and we determine every resource that we think that patient might need prior to them telling us that they need it in the worst moments of their life. And we provide it to them up front and in the beginning. That's what programs like this can do and that information can do. Now, obviously, that would require expansion, right? Developing the team, getting community health workers and community advisory groups and all of those things. But if you really do that, the long-term cost savings are immense.
Representative Kulkarni.
Thank you, Mr. Chair, and thank you for this presentation. It was, I guess, had an incredible wealth of very, very sobering, I think, information we knew or kind of anecdotally felt like was true, but this is, I think, linking together in a very, very stark way a lot of the issues that this commission talks about that are outside of the healthcare systems, but that are obviously impacting it in a very, very negative and devastating way. I was trying to take notes as fast as I could, so I might have to go just maybe slide, not each slide by slide, but whatever notes I took very quickly.
That's very on brand, Representative Kulkarni. That's very on brand.
My first question is actually your next slide, where you were talking about, or maybe you skipped over one, where the zip code level map. So Jefferson County is, right, you've got Eastern Kentucky is red, Jefferson County is blue. So I represent a part of Jefferson, which includes part of the University of Louisville, and some of those, surrounding neighborhoods. It also includes Churchill Downs. It includes part of the west of Louisville, right, the west end of Louisville, which has I think, health disparity, a life outcome of 12 years less than the rest of the city. because of the environment, right? And the quality of housing and the industrial kind of air quality and water quality and that kind of thing. So I was wondering, this particular map, I mean, if you zoom in further, will you see tiny little dots of red
Absolutely.
in the blue areas as well? And where can we find that level of granular data? Because I am very interested in that zip code level analysis.
Absolutely, I can get that to you. We have, I'm not sure, I believe it's from 2022. I don't know if we have 2023 maps done, but I can send that. I can send that for sure.
Okay, thank you. And
And a lot of great information from COVID that we got too, from zip load level data as well.
okay, perfect. That would be great. And I think I can combine probably a lot of my comments because they've been asked by my colleagues, and you've covered them in your answers. I mean, there are, I think, things that we can do on a legislative level, and you mentioned the system, right? The system of healthcare and things that you're doing outside of the system of healthcare to incorporate and bring in these social determinants of health to anticipate these longer term issues that women are facing. So really what I was hearing is trying to get more services covered under Medicaid, right? We have moved forward. There was a slate of bills in Kentucky aimed at improving maternal and infant health outcomes that included several bills for doula and midwife services being covered, including for incarcerated women. I think a lot of those have stalled. I don't think we have actually had any of them pass, but they're moving forward very slowly. Would that be something, it sounds to me like that particular piece is something worth pursuing aggressively.
Absolutely, and I think that we saw from the map of the lack of primary care providers that if we don't fill the gap with service extenders and healthcare extenders, we are going to further overwhelm our healthcare system. And doulas, midwives are fantastic examples, and paying for them and making sure that they're funded by Medicaid actually will save money long term. And there's multiple states that have demonstrated that.
And that, yeah, so I'm just trying to think of like what can we do about it, which bites of the elephant can we start with? And we have, I think, started, but we need to figure out what is the most, I guess, return bang for our buck in terms of what we're going to be implementing, which brings me to the system level stuff. So we have a shortage. I think you mentioned, I mean, my brain kind of froze when you said 90% shortage of OBGYN providers. We already have the majority of our counties in Kentucky with zero providers for our folks to access at all. Yet there are plenty of people, you know, possibly going into other fields in medicine because they're more lucrative, they're more stable, they, you know, whatever it is. What can be done on a system level for that? Like, does that require state level funding? Does that require an overhaul of the healthcare system? Like, what are we talking about in terms of scope?
So when you ask a college senior that wants to be a doctor what kind of doctor they want to be, their vast majority of answers are primary care physicians. But something changes during their training where the cost of an education, all of those things make other priorities bigger. But if you take those kids, and I think this again goes back to that pipeline that they mentioned, if you take those kids and you say, not only do we want you to be that family medicine doctor, we want to help you make that happen. And we want to have you be that family medicine doctor here in Louisville or Lexington or your hometown. That's how you do it. Because they found studies, states like South Dakota that don't have a medical school actually pay other universities to send their kids to medical school there and then have them come back. And it has been it's how they fund and how they pay for their doctors. It's how they get their doctors to come back to their state and give service. Now it's not forever because it's years for service and years for school, but it has stabilized their physician workforce and allowed them to have a consistent workforce that's there. I think that, you know, in Kentucky, we're actually blessed in that we have 3 degree granting medical schools in Kentucky, which is more than a lot of states have. So we're not behind the 8 ball when it comes to that or the amount of physicians we're turning out. We're behind the 8 ball in how we are encouraging these physicians. And most of those physicians are from Kentucky, the vast majority. We're behind the 8 ball when it comes to how do we get those physicians to continue their interest in primary care and choose to practice here when they're done.
Thank you. I have several more, but I'll ask them offline. Thank you, Chair.
Senator Berg?
You might be able to confirm something for me, sir. I have heard rumors consistently, including this last weekend, that out of the 7 OBGYN residents that completed their training last July, 6 of them left the state.
In our residency program, that is partially true. However, some of that was because they were pursuing subspecialty fellowship, so they moved out of the state for further training.
So we have some hope that they may return.
So we have some hope that they may return. I will say that so the OBGYN residency programs, I will use Louisville for an example. The vast majority of the OBGYNs that train at Louisville, those that stay in Louisville work in the surrounding community, in the Louisville area as well. A very small amount go to Appalachian regions or rural regions. So we are not replacing the physicians that we're losing as much as we are graduating them as well.
So do we need to be actively scouring these underserved areas for potential students?
So there are so many opportunities in so many states that have programs in place to attempt to not just diversify, but attract students to rural medicine and medicine in the Appalachian regions. Absolutely, that would be the most efficient way. There's schools like U of L actually has programs for students that are interested in careers in rural medicine. That is the easiest way to identify those children. And most importantly, to also impact a generation for the students, for taking a child that wasn't, necessarily from a family of physicians and support them in the process to becoming physicians. There's so many benefits to it. The pipelines is a big way, particularly for states who have problems securing their physician workforce. It's got to be a huge way.
Thank you.
And I guess to add on to that, I think a lot of people are really excited about the possibility of EKU adding the DO program.
Absolutely.
Just because of its proximity to Appalachia.
Yep.
And how that could be one of the things to help solve that problem. I think in addition to, Hazard, turning Hazard into a 4-year accredited institution where we start to identify very early kids from the region who may have an aptitude to go into medicine. Representative Kulkarni, you had another question?
I did. Thank you, Chair. And it's something that was prompted by a response to Senator Berg's question. So we do have a foreign physician program, right, that specifically allows for them to move through the immigration process if they serve in rural or underserved areas, right, whether it's high poverty or rural counties. Is that helping at all, or is that something that could help, potentially a tool that could be used to stabilize in some of these regions healthcare providers?
It absolutely is a tool that could be used to stabilize services in particular regions. I would say that it's very largely dependent upon the healthcare organization. There are some additional barriers to having to pay for things like visas and those kinds of things. Sometimes it's licensing. The United States is very oftentimes requires residency or fellowship be done in the United States. So you will have trained, physicians in their home country that can't practice a specialty necessarily that they did here. But creating opportunities for those physicians to, if they wanted to retrain and then stay here and practice, absolutely would be a strategy. We all know we need more family medicine physicians and primary care physicians, so increasing the number of residency spots for those with an intention of staying here would be a fantastic initiative to put forth. There's so many ways to go about it. I think it's really just that it has to go back really deep, like the pipelines, and it also has to start in a couple of years, with those physicians that are kind of in place, because we are losing, and the physicians that are working in rural Appalachia right now are at that 50 to 70 year mark, where it's they are retiring at scary numbers compared to what we're replacing them with.
Thank you.
And I think to go into that, because I think I have family members that live in Appalachia, and I had a relative that had some heart issues, and he had a new doctor, a new cardiologist had come in from Bangladesh, and he my relative wasn't the most worldly as far as his understanding, and he stopped going. And he had had partial blockages, stents, all kinds of issues. And I asked, so why aren't you going to see your cardiologist? And, well, threw out a stereotype. Yeah. I said, okay, I understand, but this is care. Yeah. This is care that you need to receive. And I don't trust him, was the response. And let's look at this, what the topic of this issue is. I mean, it's a trust between patient and care provider, and for whatever reason. And those are, you mentioned the doulas and how that relationship looks a little bit different. And I think that one of these topics that we're going to rely heavily on as far as improving care is that patient-doctor relationship. And sadly, as a world, we went through a pandemic where science and doctors were discredited for trying to help. Yep. And we're in a spot now where medicine, where healthcare, particularly women's healthcare, has in the battleground. It is in the battleground. We see a lot of the residual issues, and we're going to. I know when the pandemic hit, and I was discussing with some friends about getting vaccinated, and lo and behold, I had a former student, African-American young man who's a teacher. I'm not getting it. And so I shot him a text. I was like, man, why? Come on, we'll go get it together. I don't trust it. I do not trust it. And I said, well, I'm going to get it. He's like, well, they'll give you a different type. And I said, well, go with me and we'll have them switch at the last second. Come on, I'll do that. And for me, that was, I'm a former history teacher. I know about the Tuskegee experiments. Yeah. That's a very real thing that the government performed. The government was well aware of. The government denied care for a race of people. So as you all move forward through different General Assembly, different legislative sessions, you have to remind people that the reason why race is important, because race was really important at one point, and it was written into law. You got it. It was about housing. It was about education. It was about health care. The Tuskegee experiments went all the way into the 70s. You got it. I was born in 75.
It's the support person that's taking you to your prenatal visit might have lived through Tuskegee. Right? And that's why it's so real is that mistrust is in the room with them.
And I just think one of the early topics that I remember is sickle cell anemia.
Absolutely.
How doctors denied patients claiming pain. No, you're just looking for some type of an opiate. You're looking for a pain medication, not taking it seriously. Until a white doctor said, whoa, no, if you look at this blood sample, the red blood cells go into a sickle shape. 1 in 500 African Americans has sickle cell anemia.
And more are carriers for it. And it goes into even look at the funding that goes into sickle cell anemia, which impacts African Americans at huge rates compared to the funding that goes into cystic fibrosis.
So my point with that is that's a very specific race-related issue that we deal with in healthcare. Mm-hmm. On a very small, insignificant note, we talk about relationships. I remember the first dermatologist I went to, and he didn't even look at me. He just started yelling at me. He just started yelling. And I knew in my mind, I'm not going back there. And I didn't. And I'm a every 6-month dermatologist person. I don't need to be taking a break from a dermatologist. It's not if I get cancer, it's when I get skin cancer. All my family members have had it. Yeah. So far, I've been able to, have enough cut off to prevent it, but I don't like it.
Yeah.
I do have some specific questions. HPV vaccines. Mm-hmm. We talked about cervical cancer. Mm-hmm. In the Black community, is that vaccination feared or discredited, or are we tracking numbers there where we can see if there's a correlation there with that?
Great question. So there's increased vaccine hesitancy in the African American community. If you look at across all vaccines, I think that there's new studies that are looking at hesitancy post-COVID with the, I think, what most would say was like a successful expansion of COVID vaccines into minority communities, but there are decreased rates compared to the general population. The HPV vaccine also can be started at different times during a child's adolescence, so there's an increased rate of not completing the vaccine or doing like part of it and not completing all the shots for it. So what level of protection that gives, we're not sure, but we also know that Black women are disproportionately impacted by cervical cancer and cervical cancer deaths.
I know we have, I'm violating his HIPAA, but my teenage son, we're halfway through. That's something that's important in our household that I wasn't aware of when I was a kid.
Yeah.
And it's a very real thing, and it changes, and the vaccine includes the new strains that are identified, and it's so very important.
The disparities in boys getting the HPV vaccine is immense.
Yes.
Yep.
This last thing I'll go into, and I'm going to go into a cultural issue. I'm going to go out we're on the trust tree. We're going to go out on the limb a little bit. So I am the proud father of 3 feral sons. I mean, they are feral, barely housebroken. But each pregnancy changed for me in context with my wife. And what I mean by that is, first pregnancy, we had the baby room finished weeks ahead of time, everything. I was going to the visits. It was, it was inconvenient taking time off, but at the same time, I'm glad I did it, looking back. Second child, I became a little bit more fearful about my wife's health because, I knew, I knew enough about the way the world works and what the numbers look like. And when my last son was born, I had to put on a face of confidence and calmness halfway through the pregnancy because I knew that. Okay, so the fear was unbelievable for me. It was, my wife, I couldn't tell. I could. My wife has 2 master's degrees. I have a master's degree. We both have excellent health insurance, family members that are doctors, all the boxes to check to make sure, you're decreasing the percentage. I was still scared to death. And for our child, if they were to be born with, prematurely, like the time, the birth, everything, and that's with 2 people. I can only imagine single moms in the Black communities having to do all those additional things on top of raising their children that they might already have, jobs, secure housing, and in some cases, get on that carousel of the 20 months Section 8 housing where they have to secure it for 20 months and then figure it out again. And so I know culturally that there is this, single moms, it's just part of culture. And in a case like this, in a case of families and all the things that must be done, it is a disadvantage. And I think that, we have to have a conversation about, yes, you might have an extended family. Awesome. Not everybody does. As a principal and as a former teacher, I know I spoke with literally hundreds of moms that were fighting this battle by themselves. Yeah. And I think that is a topic that, I'm not a part of. I'm not allowed to be a part of that conversation. And I just hope that conversation is like, listen, there are hard roads to take, by chance, and there are hard roads to take on purpose. Let's have conversations about those things. And again, I don't want to put myself into it. Well, what do you know? I was told the other day that I was yelled at the other day that I didn't know what it was like to be in poverty. Making a lot of assumptions about people. But I try to be the type of person that learns as much as I can just to go, you know what? I know enough to be empathetic. I'm not trying to be something I'm not, but I am empathetic. And through education, I think it's a critical piece that we all need to kind of get on board with. And like I said, I hope there are conversations about the cultural things that make life really, really tough when it doesn't have to be. And I know it's easy for me to sit here and say that, but at the same time, is someone saying it anywhere? And if maybe this is the start of a conversation, hey, can you believe he said that? start a side conversation and start solving the problem.
Yeah.
You know, we've got major health disparities in Kentucky, period.
Yep.
We got to start talking about it.
Yep.
We're going to have to address the sensitive ones too. Thank you for your presentation today. Do we have Mr. Pryor? You got.
Thank you, and I thank you for sharing that, Mr. Chairman. And I'll say this because I think it's important that, and Dr. Miller, please correct me if I'm wrong, but I believe that the data would support, and I can use my own personal experience. So my wife is a PhD, and we have 2 children, and we had 2 C-sections, not desired C-sections, and we also suffered 2 miscarriages. And in all 4 instances, I can say that the answers that we received, at least initially in some cases, were not always clear or comprehensive or thoughtful. And I think statistically speaking, when you control for income levels, age, education, unfortunately, Black birthing people still end up on the bottom. And that is an issue within the profession, within the system, and who's doing the work and what we know about the work. And so there's a lot to be unpacked. And to that end, I wanted to ask Dr. Miller before we got out of here, one of the legislative suggestions you mentioned was about data and oversight. And I'd like for you to talk a little bit more about what that looks like. As you know, I'm in Louisville, which is home of the Center for Health Equity, which was the first Center for Health Equity of its type in the entire nation, but that it seems over the last few years has been allowed to go somewhat dormant, and it's not very active, doesn't have a leader currently. But I don't know how many of those types of institutions even exist across the state. And so if you could please talk just a little bit about the importance of data and oversight and what that might look like from a legislative perspective, and what centers like the one in Louisville could do if properly resourced and supported in all the ways.
Absolutely. So the short answer is they could do so much, particularly not only if they were properly financed and supported, but if they were integrated with other centers around the state as well. That's really where the impact comes in. That article you mentioned is that ProPublica article that's entitled "Nothing Protects Black Women During Childbirth, Not Education, Not Socioeconomic Status, Not Marital Status." There are numerous data repository centers, particularly U of L has a couple of institutes and those kinds of things that are doing their own work. All of the work is extremely siloed. I think the goal of running of a larger approach is to have ownership of that data and guide where proposals come from. So at a certain point, we have to let these social determinants of health of that data guide what our legislative options are and where our next steps are. But right now, I feel like we're doing that all on individual on an individual level, which kind of disperses your overall impact that you could make.
And just the last thing, because it came up somewhat, fibroids. And this is purely personal. I now know so many Black women who have suffered with incredible pain in issues with fibroids, and have ultimately, many of them have led to hysterectomies and all sorts of different things. What do we know about that? And what can we do to better assist women from whether that be prevention or just early stages? How can we help and support?
So this is a fantastic example of going back when we talk about the impacts of stress and weathering, right? So if you ask somebody, do you have heavy periods? What is their reference point? The first period I've ever had. Was it heavy? Was it not? Did I talk to my mom and she said it was a heavy period and it's normal? When you ask a woman with fibroids, do they have heavy periods? And you compare that to somebody that doesn't have fibroids, their periods are much heavier. They're more likely to be anemic. Their periods are more likely to be painful, all of those things. But they take that as their normal because that's their basis. As a result, they go to the doctor, similar to sickle cell. I have painful periods, all of those things. It's normal. They just kind of brush it off and those kinds of things. Increased pain, don't want to go back to your OBGYN doctor. You don't have the same level of care. When you look at measures for treatment for fibroids, it wasn't until recently where we started doing these procedures minimally invasively. It used to be that this was a major incision, like a C-section incision, that you had to have the fibroids removed. There are multiple procedures you can do to do things minimally invasively. There's actually an entire field of gynecology called minimally invasive gynecologic surgery. But fibroids was not always the main impetus towards why they would do this. Fibroids impact 1 in every 5 African American women and is one of the least funded NIH areas when you look at, especially for how many women that it impacts. It is a prime example of a problem impacting a group that has not been prioritized. So as a result, there are not a whole lot of treatment options available other than surgery and those kinds of things. There are some improvements, but this has been a long-lasting issue. And we also know that women of color are more likely to be diagnosed later and more likely to have things like endometriosis in addition to the fibroids that has been undiagnosed because they just get treated with birth control, Tylenol, narcotics, or something like that. The role of narcotic use and substance use in the management of fibroids is a big one too, because people get started on medications and they just say, take that, and then they become reliant on them as well.
Representative Brown.
Thank you, Mr. Chairman. Dr. Miller, thank you very much for a very comprehensive, insightful presentation. And with the state of reproductive care and maternal care in Kentucky and in the United States of America, that there is probably something, I would think, that maybe we could talk about legislation coming out of this presentation, and maybe you could get with us to prepare some model legislation or take model legislation from somewhere else around the country. And maybe we could do a great service for the women of Kentucky by getting a piece of legislation that would hopefully pass muster in our General Assembly.
Absolutely.
So thank you very much for making me smarter as a result, making us smarter as a result of your presentation. You did awesome. It was an awesome presentation. Thank you very much.
Thank you so much.
Thank you, Mr. Chair.
Yes, sir. What role does bias have?
Ooh.
Sorry, that was a fastball right down the middle, wasn't it?
Yeah, I wasn't ready. Bias plays an enormous role. Bias, implicit, explicit, bias impacts when we talk about maternal health. And I'll use the example of, you mentioned, the single mom who's going to the doctors, and in that patient, bias impacts her in multiple ways. The bias and the grace that she doesn't get is that the healthcare system doesn't assume that she's doing her best. They are biased when she's 10 minutes late for her appointment because she had to take the bus to get to this bus to pick up the child, that she doesn't care as much about her pregnancy. They're biased that when she missed the other appointment with a no-call, no-show, that there's a reason why. Bias plays a huge role in the reinforcement of the same cycles that we see that are negative in the healthcare system. And again, when we talk about doulas, that bias, there's got to be independent ways to break through episodes of that bias. And the other one of the benefits of the doulas is that many doulas do the work because of their own personal experiences with the healthcare system, and it's almost a way to break a cycle as opposed to continuing it and perpetuating it.
This will be my last question. I know in licensing occupations later this week, we're going to be discussing birthing centers. Mm-hmm. For all of the reasons stated, the size, the relationship involved with the people, I'm on board. We used a registered midwife for our second child, so we have, it's not exactly a doula, but it's definitely kind of out of the traditional realm.
Yeah.
But where do you fall with birthing centers?
I think I trained in California, so I have a lot of experience with birthing centers. I think that the pros of a birthing center are immense. I think patient autonomy. I think ability for a patient to select a birthing environment that they feel would free them of a lot of the triggers that other hospitalized births would do would be beneficial and maybe relieve some bias. I think that anytime you make a healthcare decision, you want to make sure that you feel that you made it under your own autonomy, and I feel like it gives birthing people autonomy back in their healthcare decisions. I think there are some things that you have to be cognizant of with the expansion of birth care centers. Birth care centers, some of them run as private, for cash businesses, and that I think misses the equity lens that a birthing center could do. I also think that with a birthing center, you have to make sure that if they are serving a more vulnerable population, that they have close relationships. Should birthing things can go wrong, and that those transfers and those relays and getting them into higher levels of care must be able to be made safely to keep everyone safe.
Can you hit pause?
Yeah.
Because that's my holdup. It's that piece. It's when something goes wrong, and it seems like some of the feelings that I've been getting when I ask that question is that they feel like that part imposes more of a hospital feel on a birthing center, and that's why they're naturally kind of push back on that. Like we want our autonomy, and I hear you, but like if something goes wrong, I know the reality. Childbirth is not what it needs to be, and I just know that having the relationship with a hospital, with an emergency department, with lots of pints of blood ready to go, that needs to be automatic.
Yeah.
And so that's where I'm struggling with that. And I didn't mean to cut you off, but I'm just like, that's where I hear a lot of the questions. For me, that's my hold up on that. I voted for it the first time, and I want to see that connection piece. I want to see making sure that our hospitals are prepared, and there's a collaborative that goes on between the two, and to go from there. But I didn't mean to cut you off. I apologize. But
no, I mean, I think your statement is perfectly stated. I think that I do center the fact that the midwives or the providers working these birthing centers carefully select their patients, and they carefully select them and risk reduce them. So they are the low risk patients that are delivering there. However, careful risk selection doesn't identify all risk.
Sure.
So I still think that collaboration with the hospital healthcare system. I trained in a center where we had birthing centers, and the midwives that delivered there had our phone number on labor and delivery. And if an emergency came in, they'd say, "Hey, I'm birthing at home," or at the birthing center, "We're on our way." It's that kind of relationship that you need to have. I think most importantly, birthing centers are going to require a reimagination of the integration of the academic or the hospital-based system and the birthing system, recognizing we are on the same team and our goal is the same. We just are centering the patient who has a different idea of how they want to have their experience.
I'd like to see it where we started with that connection first, and if it was okay, then you pull, rather than the other way around, because the other way around is going to cost lives. So, Representative Brown.
Dr. Miller, just one more thing, and I didn't want to leave without saying this. I think your presentation to anybody that will see it speaks to how different women are. Women that are pregnant and can get pregnant, and what happens with their bodies, and taking that into consideration, and all the things that go into that. So I appreciate you saying that, and I think as far as legislation is concerned and what we've done in Kentucky and what we're talking about doing in the United States of America really has not taken that into consideration, that men are making decisions about women's bodies, and your presentation just makes it crystal clear. Whether we'll do anything with it or not is another thing. But thank you very much for lending your expertise and bringing that out in this conversation today. Thank you very much. Thank you, Mr. Chairman.
Senator Berg. And I believe that Senator Berg, sorry.
Follow up with an honest question about these birthing centers, because I have a lot of reservations. Because the relationship is not established, and it's going to have to be established, on the fly, essentially, unless we figure out a way to do it ahead of time. And then I wonder about the liability of the receiving physician. Here you've got a patient you've never met before, you have no idea, they're coming in extremes, and why is that you're a problem.
You got it. That can really stress an accepting hospitals
Right.
relationship. But I agree with you. I think that in a perfect world, you'd be creating this relationship on the fly together, and that's what's different. So I know that at U of L, we are building the first obstetric hospital in South Louisville. That in our mind is going to be like a birthing hospital center, more largely midwifery run with an OBGYN that's on call and on backup for the center as well. I use that as kind of like the idea, but unlike a birthing center, we're going to have anesthesia there and we're going to have an operating room. So it's going to be like a labor and delivery unit, but if something really bad were to happen, they would come back to us as a tertiary care center. I agree with your reservations. I think that in a perfect world, this is a great example of how we can communicate to expand services and access to women who need them, and then take all of our own bias and just say, let's make it about the patient, and let's make it about, if this is what they want and this is what women want, let's make it as safe as possible for them and give them some oversight and not oversight, but give them some protection should something happen during their delivery.
But the patient doesn't necessarily know what the potential complications could be. Like amniotic fluid emboli. I had an OBGYN tell me she once had clearly mom had an amniotic fluid emboli. Clearly they went straight to the OR. Mom died, baby survived.
You got it.
In a birthing center, they're both dead.
You know, my job every day teaches me it teaches me that what some women want from a birthing experience differs from what other women want from a birthing experience. And for some women, their idea of their birthing experience is that there was so much trauma in a prior birthing experience that they are willing to take that 1 in a million risk of an AFE to deliver and have the birthing experience that they feel like they need. And that is and that's where I guess my bias comes in, right? Where I'm coming into it is like, your goal should be to walk out of here healthy and safe and have a healthy baby that you go home with. And they say, that's not my experience. I'll use an example. We serve a large refugee population at U of L. I had a woman who came in who had sky-high blood pressure, severe preeclamptic. She needed to be delivered immediately. And she said, no. And she said, I haven't had contractions yet. I'm only 34 weeks. And you said, you could die. You could do this. You could do this. All these things could happen. And she said, okay, that happens in my country. I'm going home to take care of my other kids. And then she came back and she had a baby. And in your head, I've got some gray hairs from that. But I mean, you recognize that like her goals or the values she brought into that dictated what she wanted for her care. Now, I agree, it is our job to make sure that they know all of the risks that can be associated with their choices. But once those risks are understood and comprehended, I then think it's our goal is to say, based upon that, how do we do this as safely as possible?
Thank you, sir.
Thank you
This
guys so
presentation today was outstanding.
Thank you so much.
And that concludes our business. Our next meeting will be November 12th. And if there are no other further questions, we are adjourned.